that going. Pull this up. We didn't get a chance to finish that up, so I just kind of want to go over this real quick. There's just a couple slides here that we'll knock out of the way. So if you have your atlas available, which you should, because it is lab class, let's quickly just run through these, and then we'll be officially done with the axial skeleton. All right, so this is one of the two atypical vertebrae that you need to be familiar with. All right, this is the first bone in your neck. This is C1, also known as the atlas. All right, those two structures that the arrows are pointing to, those are the lateral masses. Those are going to articulate with the occipital condyles, which sit on the bottom of the occipital bone, the base of your skull. And so it's these lateral masses that make up the atlanto-occipital joint with your skull and allow you to have as much range of motion when you do the nodding up, forward, and back there, okay? So then our second atypical vertebrae in the vertebral spine is C2, also known as the axis. Okay, that arrow is specifically pointing to the dens or the odontoid process. That's a process that arises superiorly off of the vertebral body. Here you can see it from this angle here. And then you can also see both of these vertebrae, all right, articulating with one another. So you can see here, there's the odontoid or dens, the odontoid process. All right, so you notice the spinous process that comes off of C2. You got these two little nubbins here, and we refer to that as a bifurcated spinous. All right, so those are your atypical vertebrae. So now when we run through the rest of the vertebrae here, all right, the remaining vertebrae are going to have all of these structures on them. So a quick review, here's the vertebral body. That's the weight-bearing portion. Just posterior behind that is going to be the vertebral foramen. That's where the spinal cord is going to exist. Then you have your vertebral arch here. And so here you'll have the pedicles, and that's going to be the part of the vertebral arch that attaches onto the posterior aspect of the vertebral body. And they make up the lateral boundary to the vertebral foramen. And then back here on the posterior and medial aspect, all right, of the vertebra, you have your lamina. The lamina are going to be located in between the transverse process and the spinous process. In fact, the left and the right lamina, they will fuse together and form the spinous process that comes off posteriorly. All right, so this slide shows you the different vertebrae for the different vertebral divisions of your spine: cervical, thoracic, and lumbar. So when you're taking your lab test, it'll ask you to identify the structure, and then it'll also ask you, where in the spine do you find this vertebrae? Is it in the cervical, is it in the thoracic, or is it in the lumbar region? So keep in mind, lumbar vertebrae have a big, fat, thick body. Cervical have much smaller because they only have to do the weight-bearing aspect of your head. The lumbar has to carry most of the weight of your body, upper extremities, right? Your chest, your abdomen, and your head. All of that is going to sit on top of the lumbar vertebrae. It has a short spinous process. The transverse processes come off the side directly. When we're looking at the thoracic vertebrae, it has a long spinous process. Its transverse processes come off like at a 45-degree angle. So it comes off posterior and lateral. Whereas when we're looking at the cervical vertebrae, right, you'll see a small body. The transverse processes come off of the body, and in the transverse processes, you have a transverse foramina. You don't have a transverse foramen in the thoracic or lumbar vertebrae. So make sure you get a good picture of all these just to have a general understanding and an idea of where you're going to find these vertebrae here. Here's the vertebral body of your C2 or the axis. It sits right below the dens here. Here's a lateral view of the vertebral body. Okay, I have a typical cervical vertebrae right here. Here you can see it from the superior view. That's the vertebral body of a cervical vertebrae. I know it's a cervical vertebrae because I can see these guys just jumping out at me, the transverse foramina. Here's the vertebral body of a thoracic vertebrae. And here's a lumbar vertebrae. See how big that vertebral body of the lumbar is? Again, the discs are much bigger there too because of, again, all the weight bearing that has to go on. Here's a lateral view of the vertebral body of a lumbar vertebrae. Here you can really appreciate how short and blunted the spinous process is. Now this picture here is showing you the vertebral arch. It's not doing a very good job because the vertebral arch should be extending from the posterior lateral aspect here of the cervical body. And it should be extending all the way back. Okay, so that's actually incomplete. We should include this area here and this area here. Same with this one here too, okay, on the thoracic vertebrae. I got one here, the lumbar vertebrae, that's way better. Okay, so the vertebral arch comes directly off the posterior aspect of the body. It includes all of this. All right, the vertebral foramen is the opening there, just posterior behind the vertebral body. Here you can see the vertebral foramen on a thoracic vertebra and the vertebral foramen on a lumbar vertebra. All right, back up to the C1, the atlas there. There's the transverse process on C1. Here's the transverse process on C2. And then here's the transverse process on one of our typical cervical vertebrae there. So you'll notice that those transverse processes are more anterior. They're off to the side of the vertebral bodies. All right, here's a transverse process from a thoracic vertebra from a posterior view here. You can see it from the lateral portion. And then from the superior view, there's a transverse process. All right, now we can see the transverse process of the lumbar vertebrae. That comes pretty much right out from the side, more laterally there. And then you can see it here from the lateral view, kind of superimposed. If I'm going fast, I apologize, but you can always replay the videos if you need to. And a lot of this should already be labeled as we went through this before last week. All right, here's the C1 atlas. There's a transverse foramen, okay? Sits just lateral to the lateral masses there. Then you can see the transverse foramen on C2. Okay, quick review. Articular processes, real simple. If the articular process comes off the top part of the vertebrae, it's the superior articular process. If the articular process comes off the bottom portion of the vertebrae, it's the inferior articular process. And then we have this other structure called the articular facets. I use the analogy, all right, that the articular facets are like your fingernail on your finger. So your nail, or excuse me, your finger would be the articular process, and then the articular facet would be your fingernail. And just to review, the articular facet is going to be the actual joint surface that's going to make contact with the other bone that is making up the joint. Okay, so facets should be smooth, they should be flat. Here is just the C2, and you notice there's the superior articular process. Now, specifically, that arrow is pointing to the facet. So if you put down superior articular facet, you wouldn't be wrong. All right, this one here is showing the superior articular process because it's coming off of the top portion of the superior portion of our vertebrae. Here's that nice transverse foramen. You'll only see these in the cervical vertebrae, nowhere else in the spine except for the cervical vertebrae. That's where the vertebral artery and vein are going to be located. And that arrow there is pointing to the superior articular facet or process. Okay, so on a test, if the arrow is pointing to this area here, you would write in superior articular facet. Here's a superior articular process on the thoracic vertebra. Here you can see the superior articular process on the lumbar vertebra. All right, I don't like that one. And then there's the inferior articular process on one of our cervical vertebrae. There it is on the thoracic vertebra. And then there it is on the lumbar vertebra. And then another picture of our bifurcated spinous there. There's this, we'll skip that one. There's a nice spinous process in the cervical vertebra. And here it is on the lateral view. Okay, spinous process for the thoracic vertebra. And you can see it on the lateral view here. See how long that spinous process is? Again, thoracic vertebra have a long spinous process. And then there's a spinous process for the lumbar vertebra. Okay, all right. Intervertebral foramen and intervertebral disc, real simple. If you see the spine with the vertebrae stacked on top of one another and you see an opening here in the lateral portion, that is the intervertebral foramina, inter between two vertebrae, foramina, rounded hole in a bone. This is where the spinal nerves exit out of the spinal canal. Then our intervertebral discs are those fibrocartilaginous structures that sit in between the vertebral bodies. They help add flexibility to the spine, but also help as shock absorbers. So you can see a nice, good close-up here of the intervertebral foramen. So your spinal nerves exit out and they go out to either your upper or lower extremities or out to the organs or tissues throughout your body. There's an intervertebral disc. All right, now we're moving down to the inferior portion of the spinal column there. And you can see the sacrum. At one point, there were 5 individual vertebrae that fused together. So on the lateral aspects there, you have the sacral ala, A-L-A. And then you have the holes in the sacrum, and those are known as the sacral foramina. I do not require you to write in anterior or posterior. Okay, just write in sacral foramina. And if there's only one arrow pointing to the hole and you say sacral foramina, I'm not worried about it. Foramina is plural for foramen. And then we have the auricular surface. This is the actual joint surface that is going to articulate with your os coxa, which are your hip bones. So in the pelvis, you won't be able to see this. The only time you can see this structure is when the sacrum is all by itself, when it's not articulating with your hip bones there. Here you can see it from this angle here. There's the coccyx, your tailbone. It's the last division of your vertebral column there. All right, let's get to the rib cage here. So the rib cage is made up of your sternum and your ribs. So the sternum has 3 parts to it. The most superior portion is the manubrium. That's where your first rib and your collarbones or clavicles attach onto. So there's the manubrium. So you have this little depression. Okay, it's a notch-like structure, so we call it the jugular notch or the suprasternal notch. It's located between your 2 clavicles or your collarbones, so you can feel it. Feel your collarbones and go right there in the middle, and you'll feel this little dip there. Okay, that's the jugular notch or suprasternal notch. Okay, the longest part of the sternum, there's the sternal body. That's where ribs 2 through 7 attach onto. ribs 2 through 7. And then the inferior most portion of the sternum is the xiphoid process. The xiphoid process. All right, let's finish up with the ribs here. Okay, the ribs are a flat bone. There's 2 distinguishable ends. The end that attaches onto the vertebra is going to be the vertebral end. And then the flattened end, that's going to have the cartilage that's attached to it that'll eventually, at least for ribs 1 through 10, attach onto the sternum or another costal cartilage. That'll be called the sternal end. So this end here with the knob on it, that's the, well, here, let's go with the pictures. Right, that flattened end there, that's the sternal end. That's going to be the end that's going to be closest to your sternum. And then this end is where the rib articulates with the thoracic vertebra. That's the vertebral end. So the knobby end here is called the rib head or costal head. Okay, and where it tapers down, that is called the neck, the rib neck or the costal neck. And then you got another bump there, and that's called the costal tubercle or the rib tubercle. And that part of the rib attaches onto the transverse process. So we talked about it last week. Ribs 1 through 7 are true ribs. That means that these ribs, their costal cartilage directly attaches onto the sternum. So 1, 2, 3, 4, 5, 6, and 7. Those all directly attach onto the sternum. Another name for these types of ribs are called vertebrosternal ribs. That means the remaining ribs are false ribs. They do not directly attach to the sternum. So false ribs, we break down into 2 categories. 8 through 10, we call those vertebral chondral because their costal cartilage attaches onto the costal cartilage of rib 7. They're non-floating ribs. Our last 2 ribs, 11 and 12, are floating ribs. That means they attach to the vertebra, but they attach to nothing else. They do not attach onto the sternum. So we can call those either vertebral ribs or floating ribs. Know these names: vertebral chondral, okay, vertebral floating ribs, and vertebral sternal. Sometimes there'll be a question on that. All right, so here are all the labeling for the ribs here. Rib head, rib tubercle, rib neck, vertebral end, sternal end. And you can see how the ribs attach twice, at least if we're talking about ribs 1 through 10, right, onto the vertebral body, and then a second time onto the transverse process there. Okay, just wanted to get that out of the way there. All right, that's not what I wanted. That's what I want. Okay, so let's talk a little bit about the upper extremities, the appendicular skeleton. So keep in mind, we know what the axial skeleton is. That's the main axis of your skeleton, right? So keep in mind that the appendicular skeleton is going to be, all right, the part of the skeleton, right, that includes your upper and lower extremities and the bones to which they attach to. So today we're going to talk about the pectoral girdle. Right, so the pectoral girdle is going to be, right, the bones that are going to, yes, support the upper limbs, but also attach the upper limbs to your axial skeleton. So that includes 2 bones, the clavicles and the scapula, which is your shoulder blade. All right, so you've heard me commonly refer to the clavicle as the collarbone. And I only did that because we haven't covered it yet. I'm going to be referring to it as the clavicle now, because I don't want you to keep thinking collarbone and then write that down in a test, because that would be an incorrect term to use. We want clavicle. So it looks like an S. And so it's going to extend from the sternum, specifically the manubrium, we just labeled that, all the way back to your shoulder blade, which is the scapula. There's this process that comes off the scapula called the acromion. You don't know that yet. So here you can see the clavicle attaching here onto the manubrium. And then it extends all the way back and attaches onto your shoulder blade, specifically the acromion. And it forms what we call, you've probably heard it before, the AC joint, stands for acromioclavicular joint. Easy joint to dislocate. So the clavicle, okay, again, we're going to refer to it, all right, by some of the regions on the bone there. So the end that's closest to your sternum is called the sternal end. And that end looks like a triangle or pyramidal. And it forms the sternoclavicular joint. When we get into chapter 9, we'll talk about the different joints here. Right? And then the other end that goes back towards your shoulder blade is the acromial end. And to me, it looks like a spoon. It's described as broad and flattened. And that's going to create the acromioclavicular joint, also known as the AC joint. So here you can see your clavicle. All right, the sternal end, you have this pyramidal shaped end here, and that's going to articulate with the sternum. And then this broad flattened end, that's the acromial end. And so that will articulate with the acromion process on your scapula. All right, some of these structures you'll need to know for lab, but some you won't. All right, this one, right, you do need to know. It's called the conoid tubercle. Pay close attention to the spelling of that. All right, we saw another structure when we were talking about the mandible that looked similar in spelling to that. It was the coracoid process. Well, this is called the conoid tubercle. And it's going to be located on the underside of the inferior portion of the clavicle, close to your shoulder blade or the acromial end there. So it's this little bump here. It's tough to see. When we go through labeling, we'll show you in your lab atlas there. It's the conoid tubercle. You don't need to worry about the costal tuberosity. All right, how did the sternal end and the acromial end of the clavicle differ? The sternal end looks like a pyramid or triangular in shape. It's going to articulate with the manubrium and create the sternoclavicular joint. The acromial end is broad and flattened like a spoon. It's articulating with the acromion, and that forms the acromioclavicular joint. Which brings me to the scapula. Hooray, scapula. All right, so the scapula is that triangular bone that sits on your back. Right, we also refer to it as the shoulder blade. Right, it is another flat bone. Okay, these are the different views that you can see of the scapula. The top one is the lateral view. The bottom left is the anterior view. And the bottom right is the posterior view. So if I'm standing behind you in line to get pizza at a concert, this is the view I see on your back. You need to know which is the anterior view and which is the posterior view. It'll help make sense of certain things. Okay, so when we're talking about the different structures on the scapula, you can't help but notice this big ridge on the back portion of the scapula. That's called the spine. That's this thing. Right there. That is the spine of the scapula. At the very end of the spine is the acromion. That's this fella. Okay, so the spine of the scapula and the acromion, they're continuous with one another. And so the acromion is going to be that part of the scapula that articulates with the clavicle. Then you've got another process that's popping off of the scapula, and that's called the coracoid process. And one of the muscles, it's the site for muscle attachment. Okay, we actually name, look at the spelling of this guy, coracoid. Ooh. Remember the coronoid process that we saw in the mandible? I'm telling you, so that this is why it's really important that you get your spelling down. This is very close in spelling, coracoid, coronoid. Okay, sometimes I think they do that to mess with us, to make it harder. Okay, but the coracoid process is a projection that comes off the anterior aspect of your scapula. So it's tough to see, but that's this guy right here. Also, you can see it from this view. That's the coracoid process, and this is the acromion right here. The coracoid comes off the front. All right, so we got a couple borders here for the scapula. Remember, it's a triangular shaped bone. So the top border is going to be the superior border. Okay, the medial border is going to be closest to your spine. And then the lateral border is going to be closest to your armpit. Also, we're going to see a couple cavities or fossas. A fossa is going to be a shallow depression, right, that we'll see on bones. So there's 3 fossas, well, actually 4 if you want to count the glenoid fossa, right? So you have the subscapular fossa, and that's found on the front of the scapula. And so there's a muscle that sits there. It's part of your rotator cuff muscles, and that's called subscapularis. When we get to muscles, we'll talk about the rotator cuff muscles. Then on the back side of your scapula, above, remember where the spine of the scapula was? Well, the muscle that's, the depression above the spine of the the depression above the spine of the scapula is called the supraspinous fossa. Supra above, spinous, the spine. And so you have another rotator cuff muscle that sits there, and that's called supraspinatus. Then below the spine of the scapula, you have another depression, and that's the infraspinous fossa, which will have our third rotator cuff muscle called the infraspinatus. So just from right there, 3 out of the 4 rotator cuff muscles, all right, reside on the scapula. Then we have the glenoid fossa or glenoid cavity. And this is that lateral structure here where I'm putting the X. That's the glenoid cavity or fossa. That articulates with your humerus to make your glenohumeral joint or your shoulder joint. Okay, the glenoid fossa. What fossa are located in the scapula and what is located in each fossa? All right, subscapular fossa is on the front. That's where subscapularis is located. Okay, the supraspinous fossa is on the back, above the spine. That's where supraspinatus is. And then the infraspinous fossa is below the spine, on the back of the scapula, and that's where infraspinatus is. Okay. So let's climb on board and get into the upper limb and talk about some of the structures on the upper limb. Okay, so let's talk about all the bones first of the upper limb. Before I do so, we've got to talk a little anatomy terms here. Okay, because a lot of times when people think of the arm, they think of the entire upper extremity. All right, now you're in anatomy, so we're no longer going to be thinking like that. Okay, so when we're talking about your upper extremity, we break it down into a couple different regions. you have the brachium, also known as the arm, which is this part of your upper extremity. That's the brachium. Then below that, you have your antebrachium or your forearm. Okay? And then finally, you have the hand. So there's three components to the upper limb: the brachium, your arm, okay, it's from your shoulder to your elbow. Then you have the antebrachium, the forearm, which is from your elbow down to your wrist, and then obviously the hand is your hand. So when we're talking about the bones of the upper limb, okay, when we're looking at the bones of the brachium or your arm, there's only one bone, that's the humerus. Your forearm or antebrachium has two bones, the radius and the ulna. Then your wrist has 8 bones. Those are the carpal bones. Then the palm of your hand, okay, contains your 5 metacarpal bones. And then your actual fingers, right? We call those phalanges, the bones of the fingers. And you have 14 phalanges. So you have 5 fingers, but you have 14 phalanges. That means that one of the digits has 2 bones in it, and the remaining digits have 3 bones. We'll talk about that. All right, so let's start off with the humerus, largest bone in your upper extremity here. Okay, this goes from your shoulder down to your elbow. It's going to articulate with the radius and the ulna to form the elbow joint. There you can see the humerus there. Okay, so humerus is a long bone. So long bones have a diaphysis, and then they have a proximal and distal epiphysis. So the proximal epiphysis, we call that the head of the humerus. And so it's going to articulate with the glenoid fossa or cavity to make the glenohumeral joint. All right, so on the proximal epiphysis, there's a couple of structures there. We've got the greater tubercle and the lesser tubercle. Okay, the greater tubercle is going to be lateral to the head, and the lesser tubercle is going to be medial to the head. And then in between these two tubercles, a tubercle is a bump. Okay, and in between these two tubercles is this groove called the intertubercular sulcus, or the intertubercular groove. And it's important that you know this because this is where the tendon of the long head of the biceps brachii muscle resides. A lot of times people will complain of shoulder pain, right? And they'll point to the front portion of their shoulder. And there's a test that you can do, right? And basically you have the person straighten their elbow out, put their hand, all right, put their arm directly in front of them, pointing straight forward. And then you push it off to the side slightly, turn the thumb down. And what you'll do is you'll ask them, all right, hold that position. I'm going to try to move you out of that position. And if you try to push on it and they're in excruciating pain, it's because the long head, the tendon of the long head of the triceps brachii muscle is aggravated and it sits right in that groove. Or if you really want to do an easier test, just push in that area on the shoulder. And if they come flying off the examination table, then you know that it's the tendon there. So when we talk about our long bones, you heard me mentioning, all right, you have a diaphysis, which is the shaft of the bone. You have the epiphysis, which are going to be those knobby ends of the bone. And then where the epiphysis kind of tapers down into the diaphysis, you've got the metaphysis there. In the metaphysis, we'll see the epiphyseal growth plates. Okay, well, with our humerus, we've got 2 structures here, okay, that are going to be, this is the only bone that has this phenomenon, where you have 2 necks. Usually the neck is where the head starts to narrow down into the diaphysis. So we have an anatomical neck and a surgical neck. The anatomical neck is where you're actually going to see, all right, where the epiphyseal growth plate used to be. And then the surgical neck is where you actually see the actual narrowing of the head, of the epiphysis down into the diaphysis. All right, surgical neck is clinically significant because quite often that's where, if the bone's going to break, it's going to break at the surgical neck. All right, you've got this bump on the lateral surface there. That's called the deltoid tuberosity, named after the muscle that attaches there. And then if we go all the way down to the distal portion of our humerus, right, we have our medial and lateral epicondyles. So if you feel your funny bone, okay, and I'm sure some of you are familiar with what the funny bone is, you'll feel this bump on the inside of your elbow, this bony projection. That is the medial epicondyle. And when you hit that, you irritate this nerve here, the ulnar nerve, and you get that weird sensation, like that tingling feeling there. People call it their funny bone. I don't know why. There's nothing funny about it when you hit it, but you'll see that these epicondyles are going to be on the distal portions of the humerus. And epicondyles serve as sites for muscular attachment. So obviously the medial one will be on the inside of your elbow, the lateral will be on the outside. The medial is more pronounced. Then also at the distal end of our humerus, we have our capitulum and our trochleum. The capitulum and the trochlea, all right, are these smooth surfaces, all right, that are specially formed because of the bones to which they articulate with. So the capitulum is going to articulate with the radius, and that's located laterally. And then you have the trochlea, which articulates with the ulna, and that's going to be medial. Okay, so here's the humerus right here. So here's the medial epicondyle, your funny bone. And off to the side here, that will be the lateral epicondyle. Then you see you have these two rounded, well, these two smooth structures, the trochlea here and the capitulum here. The capitulum is just like a ball. Where the trochlea, to me, the trochlea looks like a bow tie. Some people describe it as a dumbbell, but it kind of looks like that. I got better pictures. Okay, so the trochlea is going to be more medial. It articulates with the ulna. The capitulum is going to be more lateral, and that articulates with the radius. All right, so we saw the landmark structures on the distal end. Now let's talk about some of the structures that involve depressions. And there's three. Okay, two are going to be on the front and one will be on the back. So let's start with the one on the back first. That's the olecranon fossa. And the olecranon fossa is on the back side of your humerus. And so when you extend your elbow, when you straighten it all the way out, part of your ulna, which is one of the bones in your forearm, okay, part of that bone is going to enter into this fossa. And if that fossa wasn't there, you would not be able to fully extend your elbow out straight or close to straight. I can't extend my arm all the way out to 180 degrees. Some people can go past 180 degrees. All right, but if you didn't have the olecranon fossa there, then you would only be able to bend your elbow anywhere between 100 to 120 degrees. It's because of that fossa, part of the ulna moves into that little depression, and so you can keep extending your elbow. Now on the front side, you've got two fossas, and they're named for the bones or the part of the bone that to which they're going to accommodate. So on the anterior lateral portion, that's the front outside, right, you have the radial fossa. And so that's going to accommodate the radial head. That's the bone that's on the lateral portion of your forearm. Then you have the coronoid fossa. Well, I'll be darned. Look at that. Does that look familiar to you? Coronoid? Yes, it should. We talked about the coronoid process that was located on the mandible. And we saw earlier in class the coracoid process that comes off the anterior aspect of the scapula. Okay, so just again, just another reminder, spelling crucial. So the coronoid fossa is going to accommodate the coronoid process of the ulna. When we start doing labeling, I'll review all that. So keep in mind, these fossas are depressions. So you have two on the front, there's the radial fossa, and then right next to it in that circle that I just drew is the coronoid fossa. That's on the anterior aspect of the humerus. On the posterior aspect here in the back, there's the olecranon fossa. All right, so here you can see the elbow joint and the bones and how they articulate with one another. All three of those bones make up your elbow joint. All right, nice X-ray lateral view and an ADP view of the bones. All right, what is the difference between the anatomical and surgical neck of the humerus? The anatomical neck is the groove that represents the epiphyseal plate. That's where the growth plate closed. And we'll see that, all right, between both the lesser and the greater tubercle, the head of the humerus there. The surgical neck is where we actually see the epiphysis start to narrow down into the diaphysis, but clinically significant because it's a common fracture site. All right, so what portion of the humerus articulates with the radial head? All right, that would be the capitulum. The capitulum is the ball. The radial head, I'll show you here in a moment what it looks like. And then what portion articulates with the trochlear notch of the ulna? That's going to be the trochlea. All right, so the forearm is made up of two bones, the radius and the ulna. They are parallel to one another. Keep in mind, the radius is going to be on the lateral part. So when we're talking about what's lateral and what's medial, we're always in reference to the anatomical position. So to review the anatomical position, that person, since we're talking about the upper extremity, is standing upright, facing forward, and their arms are out to their arms are to the side, hanging down, and the palms are facing forward. And so in that position, the radius will be lateral. All right, so here you can see the two bones. The longer of the two bones is the ulna. The radius is the shorter one. So this end is going to be the proximal end. That's going to be where the elbow is. This end, well, you can see this is going to be where the wrist is, down here. Okay, so let's talk about the radius. So the proximal end of the radius, the head looks like a disc. So it looks kind of like this. Like that. Except if you're looking at it from the top, there's a depression here. And that's where the capitulum sits in. Because remember what I was saying, the capitulum is a ball. It sits right there. Okay, so it's a disc. So if I was looking down at the head, it'd be circular with this depression in there to accommodate the capitulum. So where the radius starts to narrow down right here, that's the neck. And then you're going to see this bump not too far from the head of the radius. And that's called the radial tuberosity. That's where your biceps tendon attaches. You can palpate that out. And for those of you that have ever taken blood pressure, it's a very important anatomical landmark. Okay, so if you feel in the front there of your elbow, you'll feel this tendon there. If you go just medial to that, about an inch, not even, you'll palpate out your brachial pulse. I'm doing it right now as I'm speaking to you. So when you go in to get your blood pressure taken, and the medical personnel puts the blood pressure cuff around your arm and starts to inflate it, then they'll take their stethoscope and they will palpate out the biceps brachii tendon there. They'll move medial to that, and they'll place their stethoscope right over that area, over the brachial artery. And so they can listen to your blood pressure. All right, so the radial tuberosity is going to be closer to the proximal end of the radius. At the far end of the radius, you've got two structures. Okay, you've got this little bony projection called the styloid process. Okay, that's going to be at the distal end. So if you want to palpate out the styloid process, you can do it on your wrist right now. Just go to the fingers of your other hand on either side of your wrist, and you'll feel these two little bony things on either side. And the one that's on the side of your thumb, because that's where your radius is, that's your styloid process. The ulnar notch is going to be on the medial surface of the radius. And this landmark or structure is going to directly articulate, right, with the ulna. So we call it the ulnar notch because the ulnar just kind of nestles in there. All right, the ulna, the longer of the two bones, the more medially placed bone in your forearm. All right, so when we're talking about the ulna at the proximal end of the ulna, right, you are going to see a couple structures. You are going to see the olecranon, the coronoid process, and the trochlear notch. All of those are located at the proximal end by your elbow. All right, we'll get into that. At the other end, okay, the distal end, you are going to see the head of the ulna and the styloid process. Let's skip that. So, I'll talk about the other stuff when we do the labeling. So you may have noticed on some of these pictures here, in between the two bones, you have this kind of whitish structure there. That's called the interosseous membrane. All right, and it's made up of dense regular connective tissue, so it's like a ligament. But the nice thing about the interosseous membrane is, one, it forms a joint there, okay? But this tissue keeps both the ulna and the radius at a fixed distance apart from one another. So they're not bunching up, because there are soft tissue structures in here, nerves, muscles, all sorts of stuff. So we can't have everything getting crowded. Okay, we can't have all that getting crowded. So it acts as this pivotal point. So when you're doing rotation of the forearm, like supination and pronation, that interosseous membrane helps with that. Okay, we'll talk about this in chapter 9, right, when we get into the different types of joints. All right, but this joint is called the radial ulnar joint, and it's mainly because of this interosseous membrane there. Which brings me into supination and pronation. Okay, now we'll talk more about what that is also when we get into chapter 9. But for right now, when you are in the anatomical position and both of your palms are facing forward, all right, the radius and the ulna are going to be parallel to one another. So when your palms are facing anteriorly, we call that supination. But now, how I remember it is, if you bend both of your elbows, okay, and your palms are facing upwards, bring your palms together, like if you've been walking out in the desert for 4 days, you haven't had a drink of water, and you come across an oasis, and you start scooping water with both hands into your mouth and drinking it. That's the position I'm talking about. I think of that as, I'm going to hold soup in my hands, preferably not hot soup, especially if I've been in the desert for 4 days. Okay, so you bring both your hands together, you cup them together to hold your soup. That is, your forearm is in the supinated position. which means both the arms of your both the bones of your forearm are parallel to one another. Okay, so now when I go into pronation, basically all I'm going to do is I'm going to turn both my palms down towards the floor. Or if I'm in the anatomical position, I'm just going to take my palms and turn them facing backwards or towards the posterior. That's called pronation. Look what happens to the radius and the ulna. Okay, the radius and the ulna pivot on each other because of the interosseous membrane. And so you can see how the radius just crosses over, but it's still at that fixed distance because of that tissue there. But that's what happens when you pronate. Okay, now the bones there, the radius and the ulna, are no longer parallel. Okay, the radius is crossed over. All right, let's move down into your wrist, the carpal bones. There are 8 bones. All 8 of these bones are going to form your wrist. They are arranged in 2 rows. The proximal row, that's going to be the row that's closest to your elbow. And then there's the distal row. That's the row that is going to be closest to your fingertips. Wow, Dr. Kaz, why did you type that on the screen? That's a great question, student. Let me tell you why. Right, I am not big into mnemonics, okay, but this is one of the few mnemonics that I remember from med school, okay, and I actually saw it on a show called ER. It used to be on NBC a long time ago, and so mnemonics will help you with memorizing certain things. So silly lovers try positions that they can't handle. So you take the first letter of each word and it correlates with a carpal bone. So I'm not going to underline every single one, but if we start up here, scaphoid, silly, lunate, lovers, triquetrum, tri, pisiform positions. Then that, trapezium, they, trapezoid, capitate, can't, and then hamate, handle. However you want to remember it, okay? But that's one way that people were able to, that I went to school with, were able to remember, all right, the mnemonic for the carpal bones. Okay, so the first part of the mnemonic that lists all the bones in the proximal row. And when we're doing the proximal row, we're going from outside in, from lateral to medial. Starting with the thumb, always start with the thumb. Scaphoid is going to be on the thumb side, pisiform is going to be on your pinky side. All right, I thought I'd throw that out there for you. Again, I don't have a lot of mnemonics, so don't count on me. All right. Okay, so here's a nice x-ray of all the different carpal bones in situ. We'll go here real fast. All right, what you're seeing is different views, an anterior and a posterior view. I know it's really difficult to tell of the carpal bones here. All right, so the next group of bones are the metacarpals. These are going to be the bones that are found in the palm of your hand. So they will directly articulate with the distal row of carpal bones. And so we use Roman numerals. I'm not sure if you're familiar with Roman numerals, okay, but just in case if you are, we're always going to start at the thumb. So metacarpal 1 is Roman numeral number 1. Metacarpal 2, which is your index finger, will be Roman numeral number 2. Okay, Roman numeral number 3. Roman numeral number 4. And then finally, Roman numeral number 5. That's how you do the Roman numerals. So if I see metacarpal 1, I know that you're talking about the thumb. If I see metacarpal 5, I know you're on the pinky side. So here you can see them all highlighted right here. Okay, here are all the metacarpals in the palm. So we start off on the thumb side, that's metacarpal 1, index finger is metacarpal 2, middle finger is metacarpal 3, right? Ring finger is metacarpal 4, then the pinky is metacarpal 5. That's simple, easy, easy. You should not lose any points on that. Here are all 5 metacarpals, because you have 5 fingers, you have 5 metacarpals. Then finally, we have our phalanges. Okay, the phalanges are going to be the actual digits. So we see the phalanges in your fingers. So digits 2 through 5, all right, will have 3 phalanges in each finger. Your index finger, your middle finger, your ring finger, and your pinky each have 3 phalanges. The thumb, also known as the pollex, only has 2. If you don't believe me, count your knuckles. Okay, you've got at least 2 knuckles in the phalange region of your fingers, 2 through 5, but look at your thumb, you just have that one distal knuckle there. So the proximal phalanx or phalange is going to directly articulate with the head of whatever metacarpal it's associated with. The tip of your finger is the distal phalanx. And then the phalange in between the proximal and distal is going to be the middle phalanx or phalange. Now you can either say phalange without the S, if you want to say individual bones, or you can say phalanx. Okay, so you have those 2 options. So your thumb does not have a middle phalange. All the other fingers do. The thumb does have a proximal phalange and it has a distal phalange, but it does not have a middle phalange. Okay, so if you look here on our x-rays, here are all the distal phalanges for digits 1 through 5. But look here, we only have on your fingers 2 through 5. They're the only ones that have middle phalanges. But you do have 5 proximal phalanges. Thumb does not have a middle phalange. Okay, so look, only 2 phalanges for the thumb. I cannot stress this enough. You should not miss any points on this. But if you look at the rest of them, 1, 2, 3, 1, 2, 3, 1, 2, 3, and 1, 2, 3. Okay, there you go. See them all. Proximal and distal, all the digits have 1. Middle, only digits 2 through 4. Scaphoid fracture. I just had somebody that came into my office the other day with a scaphoid fracture. Okay, it is the most commonly fractured bone in your wrist. Right? Usually what happens is someone falls down as they're falling, they stick their hand out and they land on their wrist and they damage the bone. If it's bad enough, if you damage the blood vessels, you can get this condition called avascular necrosis. We briefly talked about that before. And that's when the tissue starts to die because it can't get blood supply there. And so it does take quite a bit of time for this to heal, right? But in some cases, if you didn't damage the blood vessels, there's really not much that needs to be done, okay? And when I mean done, that it doesn't require surgery. Okay, I'm gonna stop here because I'm gonna wait to do the labeling next class. So let's stop here. And any questions?